Hello everyone, a very warm welcome to the neonatal intensive care here at Motherhood, Hebbal, which is a level 3 neonatal intensive care, has the state-of-the-art facilities for managing all types of sick newborns, surgical newborns, and we cater to almost everything that the baby needs. This neonatal intensive care unit, as I said, is a level 3 unit, and I will be taking you inside and showing you the facilities that we provide here. My name is Dr. Vikas and I'm the Chief Neonatologist here at Motherhood, Hebbal. As I welcome you, I will be taking you in, and so please follow me and then I'll show you through to my neonatal intensive care. So that is the washing area that I've come across from now, where I have washed my hands, and as we enter we have to be used alcohol hand rubs. And as I enter the neonatal intensive care, there are two areas. The one that I'm about to enter is our inborn area, where the baby is born here, or the babies that are deemed non-infectious to the other babies are treated. And this is the area which is the isolation area or the outbound area, where we place babies which we retrieve from a different hospital and brought here and treated. And once they're ready to go back home, either they are transported back to the hospital where they came from, or they are discharged back home. We have a feeding area here, which is used by the mothers to express milk, provide kangaroo mother care in the privacy. There will always be a nurse with the mother to help the mothers express the milk and provide kangaroo mother care as and when needed. We are moving into inborn area. Now the inborn area is a pretty big area here, as you can see, and I'm just going to pan across this area to just show you the amount of babies that can be placed here and that are being treated here currently. So as you can see that my nurses are busy carrying out their work, managing these babies. And this is the babies that we can hold here in this area is about 15 babies. Currently we have treating quite a number of babies here. Yeah, and I have another area which I'll take you across, where we manage highly infectious like COVID, or may it be respiratory syncytial virus that we are seeing in this season, or a metapneumovirus that we are seeing in this season. Unfortunately happening in the babies that have gone home. Maybe they are about 14 days old or 20 days old or less than 28 days, which have been managed in a separate isolation bay. So there are about 2 babies there. So you can see that we do treat for quite a number of babies in our unit. So as I take across, we have, you can see on my left side, which we have 2 babies here managed by my colleague here now, Dr. Prashant. We have 28 weekers that are being managed here, which were born almost at about 4 o'clock in the morning. The whole team was present, and we picked up these babies from our own theaters. They are currently day 3 and being managed. As I take you across here, we have 2 more babies being very small babies and very born at 900 and 700 grammars. These are being managed now currently by Dr. Prasanna. So Dr. Prasanna will talk to you later about the babies and what the conditions are. That, as you can see, these are very, very small babies, and when we say small babies, they are very tiny. They are less than a kilo, they are less than 30 weekers, and which basically means that these babies will have to be managed in an incubator, because we have to provide the warmth, we have to provide the humidity, we have to provide the infection-free environment that these babies require. They are in the various stages of management, which will be spoken by my colleagues. Just taking you across again for the other areas that we have here. We have again another little mature babies who have been through that stage and of course now come across to this stage where here they are more of feeding and growing babies. They need maybe phototherapy or they need bits of support with the feeding, and these are the babies that are soon, maybe in a couple of weeks, going to go home. On this side again we have almost the babies that are ready to go home, so they are almost like nearing graduation, if you can say. We have a baby here who was born very preterm. This baby was born at about 26 weeks and is now almost ready to go home at 30 weeks. So you can see that there are various stages of management. On the other end of the spectrum, where the intensive care bay, where we have about 24, 25, 26, 27 or 30 weekers who have just been born being managed, and at this end we have almost graduates going home doing really well. So these are the babies that are there, almost ready to go home. I just like to draw your special attention to here, to one of the babies that is being managed here. This is a term baby. Unfortunately had a sentinel event, caught around the neck, and ended up having what's termed as, in the common terminology that is used as a birth asphyxia. In the medical terminology, we label it as a hypoxic ischemic encephalopathy. Baby was deprived of oxygen and blood supply to the brain and the rest of the body for some time, just at about the time of the birth, due to a cord around the neck. So the cord wraps around the neck and prevents the blood supply to the baby. This baby is basically being undergoing a procedure that's called as total body cooling, where we circulate water into a jacket via this machine, which is a servo controlled machine, which basically keeps the temperature of this baby at 33.5 constantly for 72 hours, and this procedure is called as total body cooling. Now this has been extensively used in the Western countries to help prevent further brain damage to the babies that are born through birth asphyxia. It has shown excellent outcomes in the Western countries in terms of neurodevelopment in later stages and in preventing further damage to the brain. So that is what this baby is undergoing, this procedure. This baby is undergoing this procedure since the last 24 hours now. So this baby has another 2 days for this baby to undergo this procedure, and then we'll slowly rewarm the baby. We'll get an MRI on day 5, and we'll know the extent of the damage that we have prevented for this baby. So again, as I said, this is a procedure called as total body cooling. Now I'll take you across to the other areas where I'll be showing you about what the babies that we have received from the Outbound Units, which is basically referred from different hospitals. So this is our Outbound area where we're currently housing about 3 babies. If I can say, this is a baby that was born at 30 weeks, delivered again in the middle of the night. Our team went about 35 kilometers and retrieved this baby in the middle of the night. Required intubation, surfactant administration, stabilization, then got the baby here. And once the baby was here, this baby was on CPAP, and then we have now the baby is currently doing really well and is on nasal cannula oxygen, or what we call as OptiFlow. Basically a little bit of it's oxygen air mixture which is delivered in a slight pressure straight via into the nostrils, so slightly different from a conventional CPAP. And we have our other baby here again. This was again born in a different hospital. This is again a 31-weeker which required retrieval. Mother did not have steroids, or there was not enough time to be given steroids. So this baby again was retrieved, stabilized, intubated, given surfactant, brought here, and now again this baby is doing really well. He's about day 6 old now. It's establishing feeds, he's doing really well, has had normal head scans. This is again another baby that we have retrieved from different places, born to a mother who had diabetes, had grunting. They called us for help. We went again and retrieved this baby. Quite a couple of days of CPAP. This baby, we have taken off the CPAP today. He's doing really well. It's a 36-weeker, established feeds. Hopefully should be going back to the parents in about a couple of days from now. So again, happy story, happy ending for this baby here. So I'm already in this bay, which is isolation bay, and here basically we are managing 2 babies which are about like 27 days old, and this baby is about 26 days old. So both have different problems, but basically the same issue, which is respiratory distress. But both the babies had viruses, which I think in this season has affected a lot of babies, causing them to have breathing difficulty, coming in with a lot of secretions, and their oxygen levels have dipped down. So this baby, we think, has a respiratory syncytial virus, is undergoing extensive management in terms of chest physiotherapy, CPAPs, OptiFlow, later a lot of medications to help relieve the congestion that is happening in the lungs, and is slowly settling down. So it's been here about a week's time, and this season, I must say, has the babies have taken a hit. The economy has opened up and people have started moving around, and again a word of caution to be very careful, so it's not to spread the infection. Be careful, again use mask, hand sanitization, and go out only if and when needed. Viruses, there are other viruses out there which spread, and 2 years of isolation and not much exposure. Adults catch the infection, pass on to their babies, and the babies end up in neonatal or a pediatric intensive care with very bad chest infections that require real intensive management. So this baby has been through a lot, is actually currently settled down a lot with intensive management. Same with this baby. This baby also had respiratory distress, almost choked on his feet, had a hypoxic seizure, and ended up here. Has recovered very well and is almost in the final stages of recovery, and due to go home in the next few days. So again, which goes on to say the wide spectrum of the cases that we are managing varies from extreme preterms to term babies to post-term babies. Everything is involved.
Hi, I am Dr. Prasanna Nayak, consultant pediatrician and neonatologist at Motherhood Hospital, Hebbal. I will be briefing you about a couple of babies here in our unit. For these retrievals, these are very high risk babies, and we consultants go individually to attend these deliveries because these babies need top expert care, wherein the golden period, first 1 year of life, if we give a good care, the outcome of these premature babies will be excellent. Coming to this baby, this was a 27-weeker baby weighing around 920 grams at birth. This baby born by emergency cesarean section in view of abruptia placenta. This baby did not cry immediately after birth. We started with a positive pressure ventilation, and after 30 minutes still baby was not having a good spontaneous breathing efforts. We intubated this baby. We gave surfactant, that's Curasur there, by Insure technique. Then we extubated and we transported the baby here. What are the challenges we face during the transport of these kind of babies? First and foremost, we should be having a strong transport team, wherein we should have a very strong nursing staff who knows how to put the lines, wherein these babies usually weigh around 600 to 1 kg. So we should have a very strong nursing staff who are expert in putting cannulas, maintaining temperature of the babies in our supervision. So this baby, after intubation, we shifted this baby to Motherhood Hebbal by transport incubator. Once the baby reached here, we connected the baby to CPAP, then we secured the central lines, we sent the sepsis screen, then we started antibiotics empirically because there was a history of abruptia placenta. Then on day 1 we do a routine head scan which was normal, and this baby we continued on CPAP. On day 2, this baby became sick. Again, we put this baby on ventilator, and the procalcitonin level was more than 100, which is very bad sepsis. So this baby was on ventilator for a couple of days. On day 4, we again extubated, put this baby back on CPAP. We start the feed on day 1, it's a trophic feed. Slowly we increase the feed. Now this baby is around day 13 of life. Now the weight is 1 kg, and baby is predominantly a feeder and grower, maintaining saturation on Ram's cannula. The plan is to continue this baby on this Ram's cannula oxygenation for a couple of days, then to try to wean off the baby from oxygen and make the baby self-ventilate. Side by side, we'll continue the feeding thing along with the TPN, aminoin and intralipids. Once the baby crosses 100 ml per kg of feed, we'll take off TPN. This baby is off antibiotics now. The head scan on day 1, day 3, day 7 was normal. That's a very good thing for us. Very good now. The X-ray wise, lung is well expanded, requiring very minimal oxygen. Coming to the gut, baby is tolerating feed nicely. Infection wise, baby is off antibiotics. So basically, this baby is a feeder and grower on day 13 of life. Coming to the second baby, this baby born around 4 days back, a 32-weeker baby, but the problem here was this baby was weighing around 700 grams. So this was a severe IUGR baby, wherein there was some Doppler changes. That's why they took this baby for emergency cesarean section, and it was not steroided. At 31-weeker, mother was not been steroided. So this baby had respiratory distress at birth. Again, we gave surfactant for this baby, and we put this baby on CPAP. After 2 days, we take the baby out of CPAP, and baby was self-ventilating. From last 3 days, baby is self-ventilating. We are increasing the feed gradually. Presently, baby is around 80 ml of feed and remaining IV fluids with ongoing TPN. Baby is off antibiotics. So that's again a good thing. The head scans were normal. Infection markers are normal. So predominantly this baby will be a feeder and grower. What complication we expect in these kind of babies where severe IUGR like hypoglycemia, hypothermia, we are managing all those things, and we are anticipating those things, and we are managing accordingly. Now my colleague Dr. Prashant will talk about a couple of more cases, very interesting cases, extreme premature babies. Yes, Dr. Prashant.
Hi, I am Dr. Prashant, consultant neonatologist at Motherhood Hebbal. I am going to talk about premature twins right now, currently at our NICU. Their gestational age around 28 weeks. They born to a mother with prolonged rupture of membrane and preterm labor. She went for emergency LSCS at 4 a.m. 2 days back. Our Motherhood 3 consultants, we attended the delivery and initial stabilization. We received the baby with the new help and transported through transport incubator to our NICU. And baby was started on CPAP, and through in-short technique, we gave curacao for both the babies and extubated to CPAP. And they were started on total parental nutrition. Lines are secured within the golden 1 hour period. Initiated on trophic feeds. Currently, the routine scans done on day 1 as normal. And in view of sepsis, they were started on broad spectrum antibiotics. Currently, day 2 of life, they are started with trophic feeds. Their blood pressures are stable. They are on CPAP at 30% FiO2. Both babies' AB blood gases are normal. Once the screens are normal, we'll downgrade the antibiotics and we'll upgrade the feeds when babies are tolerated. So the plan is to repeat the neurosonogram at day 3 and again on day 7. So we are hoping that baby should come out well.
Hi, I'm Dr. Pradeep, consultant neonatologist here in Motherhood Hebbal. I'll be talking about this baby. It's a term age for gestation. Male baby born yesterday with a birth weight was 2.16. This baby had fetal distress, so we had ready for all the bad circumstances. So this baby didn't cry immediately. So we started neonatal resuscitation according to National Neonatology program. His heart rate was very low, so immediately we started, we intubated and resuscitated the baby. We sent a blood gas, cord blood gas, and started high intensive resuscitation. It intubated and put on bag and tube ventilation. So heart rate was very low, so we just started IV line and bolus was given. Then within 1 or 2 minutes, baby started having spontaneous respiration. But the cord blood gas turned out to be very bad. So we just observed for a half an hour, 1 hour in the labor room, and then we shifted the baby to NICU, and we observed for about half an hour to 1 hour about the neurological activity, and we put a baby according to the Thompson score. Baby needed cooling. So ours is one of the best unit in the North Bangalore. We have a cooling system. So we just spoke to the parents, and then cooling has got a good tremendous outcome for the neurological outcome for the neonate with depressed at birth. So we just immediately within 2 hours we started cooling. The cooling has got a machine. We got a critical machine. It is a best machine for the cooling, and it has got servo control mode. It senses the babies with temperature, and then we adjust at 33.5 degree, and cooling started within 2 hours. So right now baby, we have put a umbilical vein and artery to monitor the baby's blood pressure. So we are just continuously monitoring. We have done a EEG also. Good thing is EEG is normal till now. So we can keep monitoring. The cooling we should start within 6 hours. We are receiving the baby from outside, outbounds also, and we are cooling the babies as early as possible within 6 hours. The good outcome is there. So we monitor critically with a intra-arterial BP monitoring and EEG monitoring, which are very important for cooling. And keep the temperature is also monitoring, keep monitoring for the baby's core temperature every hourly, and cooling is about 72 hours of cooling, and then slowly rewarming over a period of 24 hours. The cooling, with this cooling we can prevent a lot of neurological outcome, the bad neurological outcome like developmental delay and seizures, neonatal seizures and infantile seizures, and there is a lot of good outcome according to the TOBY trial. With all high income countries, they showed a good outcome. So ours is one of the best center. We got a cooling, and also we got inhaled nitric oxide. This is the best center we have. So we monitor the baby for another 72 hours, and once the baby reaches 72 hours later, then we start cooling slowly, rewarming slowly, and we do MRI at around day 7 of life. This is all about this baby with a depressed at birth. Thank you.
Many thanks for going through the video where my colleagues and me have described
our NICU, and thanks for looking into the tour of our NICU. Before I sign off, I just wanted to speak about one last piece of equipment, which is this. This is a state-of-the-art transport incubator that we have, where we will be bringing in babies from outside which have been referred to us. Now this transport incubator is very special because it has got a digital ventilator, which I don't believe any transport incubator has currently in India. And this has got the capacity and is specifically been designed by us along with the manufacturers. So it's very custom built, where we have capacity for transporting twins, both ventilated. So you have one a ventilator and also a Neopuff, which is in the background, which you can see here. So both can be used. If one fails, the other can be used. Plus, twins can be brought in ventilated in this transport incubator. This transport incubator also has a facility for humidification, which is most transport incubators don't have, which is a big advantage for us when we are transporting preterm babies. In addition, it is so well knit, it is so well customized that each cylinder will last you for 45 minutes. So that's a total good 90 minutes between from the hospital down to the ambulance, or from the ambulance back to the hospital. So which is a good backup amount that we have. This is basically has got also the state-of-the-art monitoring facility. So in overall, I don't think I have personally seen a better transport incubator in India currently than this. So it's got everything that you need, plus the ability to transport twins, plus humidification, and plus state-of-the-art equipment here. You can also do nitric oxide with this. You can also incorporate cooling while we are transporting. So we have a critical machine which we can actually integrate it into the incubator, so we can also transport cooling babies. And that's the biggest advantage of this transport incubator, which has been specifically designed keeping in mind our requirements of a level 3 unit along with the manufacturers. Thank you very much once again for going through the video, listening to what we do in our NICU, and hopefully we should be of help to you in the near future. Thank you very much once again for listening to this video.